Alrighty. Good morning. Welcome to Glaucoma Lecture Series number 4. Today's topic is going to be on secondary open-angle glaucoma, presented by MediTread, an online training and educational website. And I am Ramesh Ayala from Tulane School of Medicine, New Orleans, Louisiana. Secondary open-angle glaucoma could be divided into 3 categories: normal tension, pigmentary glaucoma, and exfoliation glaucoma. When we talk about secondary, we are distinguishing these kind of glaucomas from the primary open-angle glaucoma that we discussed in lecture number 3. So these are variations of primary open-angle glaucoma. They also have open angles, as the definition, as the title tells you. But we believe that these are distinct and different from the primary open-angle glaucoma and needs to be discussed. So when patients with these variations of open-angle glaucoma present to your clinic, you have the knowledge to identify them and treat them appropriately. We'll start off with normal tension glaucoma. As the name indicates, these patients have intraocular pressures which are normal. Abnormal intraocular pressure, we discussed in the past, is 21. So anything below 21 millimeters of mercury with glaucoma-related optic nerve damage is called normal tension glaucoma. Pretty simple, right? Let's look at the history. Juan Grafe, again, he features prominently in glaucoma lectures, right? He is an amazing character. One of these days, hopefully by the time I'm done with this glaucoma lecture series, I would have gone through his history. You know, he discovered all of this and he died by the time he was 44 years old. Amazing character. He designed the surgical instrumentations. He cured some angle closure glaucoma. And he trained numerous glaucoma specialists who went on to discover and contribute to our knowledge of glaucoma, as we will see in the subsequent lectures. But again, Juan Grafe in 1857 recognized glaucoma as optic neuropathy in the setting of physiologic intraocular pressure. So that's how all of this started. He recognized this as a distinct entity even in those days. So how do you define this? A characteristic optic atrophy with associated loss of vision function in the presence of intraocular pressure below 21 millimeters of mercury at all time points, in the presence of open angles, of course. Now, it's important that I stress this at all time points, okay? So you want to make sure when you see this kind of patients that the intraocular pressure is really below 21 millimeters of mercury at all time points. And the only way you can do that is at this point in time, is to do a serial tonometry. We'll come to that a little later in the lecture. So what are these optic nerve changes we're talking about? A notch, a diffuse shallow cupping with pallor, or an optic nerve change that looks like a primary open-angle glaucoma change, and high myopic disc. So what is a notch? Unfortunately, I could not find a picture of a classic notch as I was preparing for this lecture, but I will be able to show this to you in a drawing if I can get this out. If you notice this portion of the rim is lost in this drawing, right? And these kind of, if you look carefully with your 90 diopter lens at these optic nerves with this, you cannot miss this thing. It's usually either the inferior or the superior rim where they have a localized loss of axons, and it looks like a notch, as the physical description suggests. And if you look at the vision fields for this particular patient, you will notice that they have a dense vision field loss in the opposite direction, as you may have guessed. So this is very characteristic. Once you see this, you will not forget. So pay attention to the optic nerve head when you examine the optic nerve head. Don't do a cursory exam like a lot of people do and walk out of the room. Pay attention to the optic nerve head every single time when you look at it. A diffuse shallow cupping with pallor. This we all know. We did see some examples of this in the previous lecture, and I'll try and show you some. They have a large cup, and it's almost like saucerized optic nerve head with loss of rim and shallow cupping. And some of these patients can look like diffuse cupping from primary open-angle glaucoma, where the cupping is much more deeper. And remember, the high myopic discs are more susceptible to present as normal tension glaucoma. High myopes are a distinct entity. And like I think I did mention to you in my previous discussion, these high myopes, you got to follow them carefully, especially if their intraocular pressures are on the higher side. The two entities that I follow closely, one high myopic disc and optic nerve head with drusen. When the intraocular pressures are greater than 21 millimeters of mercury, you want to follow them closely because I've seen some disasters in those patients. So here you can see in this optic nerve head, this is the size of the cup, which is pretty normal, about maybe 0.5, you would say. And on the other hand, you can see generalized enlargement of the cup, and you can see the blood vessels bending up. You can see bathing of the blood vessels. And so this is a pathological optic nerve head on the right-hand side, whereas the one on this side is the example of a normal-looking optic nerve head. Here is actually a patient of mine, and we'll discuss this particular case later in the lecture, and you can see again some degree of pallor, some degree of senile sclerotic cupping, enlarged view of another patient demonstrating the same thing. And one of the characteristics that you will see in patients with normal tension glaucoma is a peripapillary RPE loss, which is what we're trying to demonstrate here. The beta zone, which is much more pronounced in normal tension glaucoma patients compared to primary open-angle glaucoma. This has been extensively discussed by Doug Anderson in his paper. And disc hemorrhages are much more pronounced in patients with normal tension glaucoma. We discussed all of this before, but I want to bring it to your attention. What is more prevalent in normal tension glaucoma compared to primary open-angle glaucoma or even other kinds of glaucoma? So disc hemorrhages are much more common in normal tension glaucoma. And like we discussed before, it indicates probably poor intraocular pressure control. And when you do see this kind of disc hemorrhages in the setting of glaucoma, it is telling you that you may need to tighten up your intraocular pressure control management. That the characteristic feature of this kind of glaucoma is that the vision field loss is pretty dense and hugs the horizontal midline with the, as is demonstrated in this particular vision field. You can see it's very close to the horizontal midline and it's very dense. And this kind of, if you do see this change, this kind of change is not uncommon in the presence of a notch in the bottom. But here there is a little bit more than a notch that's going on, as you see inferior arcade scotoma also cutting in. And you can see the corresponding change in the OCT. Here is another example of a patient of mine who was referred in as normal tension glaucoma. You can see how characteristic this vision field is. You do not see this in primary open-angle glaucoma until it's late, but normal tension glaucoma patients classically present with these dense vision field scotomas hugging the midline. Now, these patients also have, cornea thickness that is a little below the average, 510 to 520 microns in non-rotation glaucoma versus 540 in unaffected patients. Also, remember some patients who are post-refractive surgery will have thin corneas and they can present as non-rotation glaucoma, whereas because of the thin cornea measurement issues that we discussed before, whereas in fact they probably have primary open-angle glaucoma. So, and lastly, I need to insist upon diurnal intraocular pressure via serial tonometry. It helps in diagnosis and to set target intraocular pressure in this patient population. And this is a good practice for most glaucomas in any case, unless it's very distinct and very visible at the time of presentation. But typically in all of these non-rotation glaucoma patients, I like to do a serial tonometry, wherein I ask the patient to come first thing in the morning around 7 o'clock, and then every 2 hours since from then on for the rest of the day, I like to check the intraocular pressure. End of the day, I'll look at the graph and then set the target intraocular pressure based on it. So some of these features are seen more frequently in non-rotation glaucoma from both from the diagnosis point of view and also from your OCAPS or board exam point of view. Absent RPE is seen as a crescent or halo at disc border. Doug Anderson is one of the first researchers to have reported this. Splinter hemorrhages indicating poor control, vascular dysregulation. So these patients have frequently, if you ask them questions, they will tell you that they have cold hands and feet, migraine with visual aura, and other signs and symptoms of vascular dysregulation are pretty common in these patients, especially cold hands and cold feet and migraine with visual aura. Thinner central corneal thickness, and non-rotation glaucoma is more frequently seen in women with a 2:1 ratio. So anytime you suspect non-rotation glaucoma, ask them regarding symptoms of vascular dysregulation. Now coming to the etiology, it is poorly understood. Mechanical and vascular theories, we have gone through these theories in the past in our the first lecture, I think. The relationship, the one thing that we have to stress here is if you think that the glaucoma is a continuum, on one side is IOP, so difficult to write with this. And the other side is the vascular dysregulation. I'll simply put that as V. And here is IOP on the other end. And we'll mark this as I, and bottom vascular regulation or dysregulation. So the most common kind of glaucoma that come across are patients with elevated intraocular pressure, right? If at the bottom of the slide here, you will see if the IOP is greater than 35 millimeters of mercury, more than 50% will exhibit glaucomatous damage. These patients probably have normal vascular regulation, but it's the elevated IOP that's the culprit, which is what we see in primary open-angle glaucoma and accounts for the vast majority of glaucomas. Whereas if you look at the other extreme of the same continuum, the IOP could be normal, but the vascular regulation to the optic nerve axons could be compromised for whatever reason. In those patients, the intraocular pressure will be normal, but they still develop optic nerve damage similar to that of primary open-angle glaucoma. So it is this entity that we are after in this discussion. I hope it gives you an understanding of the relationship between IOP and vascular dysregulation. To complete the topic here, IOP between 21 and 30, smaller percentage of damage, probably in the range of 30%. And if it is less than 21, even a smaller percentage of patients exhibit damage to the intraocular, to the optic nerve head. So it is this last category if they do exhibit axonal damage and optic nerve damage, we call this as normal tension glaucoma, and we believe that the etiology for that is vascular dysregulation. And how do you know this? Like I mentioned in the previous slide, you ask these patients carefully about signs and symptoms of vascular dysregulation, such as cold hands, cold feet, migraine with visual aura, etc. It's very common in this patient population. So coming to the molecular pathophysiology, I'm not going to spend too much time on this. We did go through this again in our previous lectures. Sufficient to say that there are molecular changes leading to cell shrinkage and loss of axonal transport, which sets the stage for cell death, and apoptosis. Here is a histology slide showing the normal-looking optic nerve head and one with this advanced sclerotic glaucomatous change, the picture of which I showed you in the previous slides. Note the loss of complete loss of axons in this particular optic nerve, and note that the diffuse cupping that's evident, and more than likely this patient is blind. You base your diagnosis on several things here. Okay, it's a bilateral disc changes that you need to exhibit. Normal intraocular pressure below 21 on serial tonometry. Bilateral vision field changes suggest to prechiasmal lesions. Cross, i.e., they cross vertical midline, hugging the horizontal midline. Family history of glaucoma, tendency towards intolerance to cold and migraine. So important things for you to remember. It has to be a bilateral disc change. Intraocular pressure has to be normal, and the vision field changes have to be of prechiasmal nature. They have to cross the vertical midline and hug the horizontal midline. So what's the differential diagnosis for normal tension glaucoma? It could be a primary open-angle glaucoma, i.e. that associated with high intraocular pressure, except when you check the intraocular pressure could be normal at that point in time. Remember, in Baltimore study, almost 50% of the patients with primary open-angle glaucoma, the intraocular pressure when they first checked in the screening test, the intraocular pressure was found to be normal, below 21 millimeters of mercury. So it's easy for you to mistake the primary open-angle glaucoma patients to be normal tension glaucoma if you base your diagnosis on just one reading. And that brings in the question of serial tonometry and the importance of it. Congenital abnormality of the disc. Here also, it's not uncommon for these kind of patients to be referred. I mean, almost every month I get a couple of these kind of patients referred to me with congenital abnormality of the disc. It could be just a physiological cupping or a congenital optic nerve at coloboma or tunnel. And these patients will have normal vision fields, normal intraocular pressure, and you have to distinguish these patients from those with actual glaucoma. Previous branch retinal vein occlusion patients who can progress to some degree of optic nerve changes in that quadrant and vision field loss, hugging the closer to the horizontal midline. So careful examination of vasculature should be able to distinguish this from normal tension glaucoma. And then you have physiological cupping, like I mentioned. It's not uncommon, especially in African American descent people, to have large cups. And I can't tell you how many times we get these referrals with large cups, thinking that these patients have normal glaucoma. Orbital or intracranial tumors. So this again is a big thing because you don't want to miss a post-chiasmal lesion masquerading as normal tension glaucoma. We'll have a little bit more about this later in the lecture. Sufficient to say that every 2 years I have a patient that I diagnosed with a pituitary tumor or some such sort, and has been under the treatment of an ophthalmologist for years prior to that with normal tissue glaucoma diagnosis labeled on them. Arthritic anterior ischemic optic neuropathy, again, there are clear distinctions. In the acute phase, of course, it's very easy to make a diagnosis with the changes that you see, but in the chronic phase, when optic nerve head pallor is all that you see, it may be difficult to see, but careful examination of the optic nerve head should distinguish this from normal tissue glaucoma. One big clue here is that the optic nerve head in AION patients is at risk, meaning it's a crowded disc, whereas in normal tissue glaucoma, it is not the case. Shock-induced neuropathy, what we mean here is if a patient suddenly bleeds or has a massive hemorrhage and the blood pressure drops below 80 millimeters of mercury, then the patient can have a lack of perfusion to the optic nerve head at that point in time, which can manifest over a period of time as optic nerve head pallor and corresponding vision field loss. So careful history should be, following a careful history, you should be able to delineate these kind of cases from normal tissue glaucoma. And patients more and more in the recent past, people are talking about low intracranial pressure as a cause for normal tissue glaucoma, or this could be a completely new subset of patient population. A couple of papers that came out of China and one from Mayo Clinic where they were able to isolate patients with low intracranial pressure to have optic nerve changes similar to that of normal tissue glaucoma. As you can imagine, if here is the optic nerve head, and let me see if I can draw this, and this is the eye. Okay, so this optic nerve head here is exposed to the IOP in the eye, right? And so if the IOP here is high, then of course you have damage to the optic nerve head axons. On the other hand, if you go beyond the posterior to the eyeball, and then you have the axons running towards the chiasm, and these optic nerve, this portion of the optic nerve is surrounded by the meninges, and the meninges carry or communicating with the brain, and as such will have the intracranial pressure exhibited there. If the intracranial pressure is too high, obviously it will choke the axonal flow, and that will be exhibited as papilledema. On the other hand, what we're talking about here is if the intracranial pressure is too low, then the optic nerve head, then the intraocular pressure, even though it is normal for that particular patient, could be too high for that axonal flow to occur in the presence of low intracranial pressure. And so it looks like we need a normal intracranial pressure and normal intraocular pressure for this axoplasmic flow to occur at the normal rate. And a disturbance in the balance between the ICP and the IOP could lead to optic nerve changes suggestive of glaucoma. Now, one other big clue in anterior ischemic optic neuropathy, shock-induced optic neuropathy, etc., or the branch vein occlusion, etc., is that the vision field change that you notice is not going to progress, whereas in patients with normal tissue glaucoma, it does progress. Patients with physiologic cupping, of course, their vision fields are normal, and more than likely their OCT, retina layer measurements are also going to be normal. Now, there are some patients, like I was mentioning before, where the intraocular pressure, when you first examine these patients, could have normal, could be normal, and you can mistake these patients to be normal tissue glaucoma. Of course, the most important being primary open-angle glaucoma. I mentioned in the previous slide, more than 50% of the patients with primary open-angle glaucoma on the initial reading can have normal intraocular pressure. Okay, and so very important point for you to understand this. But in this slide, what we are trying to do is to distinguish those patients who are having intraocular pressure that is intermittent in nature, and we cannot detect it in the initial clinical exam. So the causes for that include intermittent angle closure. So it's extremely important that you do a gonioscopy, and the way to distinguish or diagnose intermittent angle closure, of course, is via gonioscopy. And you will see when you do gonioscopy, then the angle is extremely narrow, and likelihood of scattered PAS formation or pigment deposits in the angle corresponding to where the iris is rubbing against the angle during the intermittent attacks, and the history of angle closure, including that of headaches and seeing halos around light, and temporary loss of vision, etc., would indicate intermittent angle closure. Glaucomatous cyclitic crisis, typically seen in 20 to 40 year old, more frequent, I believe, in females than in males. And these patients usually present with monocular and rarely bilateral subtle change in the vision. And when you examine these patients during the crisis period, they will have mild conjunctival injection. We will discuss this in detail later, but for the sake of completeness here, they will have mild conjunctival injection, mild corneal edema, with KPs in the same location as the Krugenberg spindle, and the intraocular pressure classically will be between 30 and 50 millimeters of mercury. These patients, this attack may last anywhere from 2 to 6 weeks, and usually responds to temporary measures such as Diamox and topical medications, along with Predforte, some steroids, even though it is not that much, it doesn't respond to steroids as much as a normal uveitic eye would respond. But we still treat these patients with 4 times a day Predforte and glaucomatous anti-glaucoma medications, and usually they do respond and go away. But in some patients, the cyclitic crisis can become frequent. And in that situation, the trabecular meshwork undergoes permanent change, and they can have elevated intraocular pressure in the long term. But during the attacks, during the attacks, the intraocular pressure is so high that left untreated, it can leave you with optic nerve changes. That's the point of this in this slide, the reason why we're bringing this up in this slide. So this is considered to be a trabeculitis, and a lot of people believe this is of viral etiology, even though it's not confirmed. One good way to distinguish this sometimes is to examine the angle real carefully, and you might see some KPs in the trabecular meshwork angle structures. Previously elevated intraocular pressure, such as burnt-out pigmentary glaucoma. Of course, in these cases of burnt-out pigmentary glaucoma, you will be able to see pigment in the angle, and other signs of pigmentary glaucoma, such as transillumination defects, etc. Past steroid use, some patients, as we do know, are steroid responders, and it could be that they were on chronic steroid use in the past for a few months to a year, during which stage they have sustained elevated intraocular pressures, and of course they probably have and if they have not had a regular eye checkup during that period, and at a later date the steroid use is discontinued, you will see these patients come to your clinic several years later with optic nerve damage and vision field loss and normal intraocular pressure. So taking a history, proper history, is very important. Past history of uveitis, again, these patients could look for PAS formation or old KPs and a history of redness and and especially in the area that I practice, sarcoidosis is pretty common to present this way. And look at the history of their medications, especially if these patients are beta blockers for any reason, for hypertension. It can lower the intraocular pressure when you examine the patient. And last but not least, central corneal thickness. I can't stress how important it is for you to measure the CCT, and a history of LASIK. All of these situations, you can miss the intraocular pressure, or the intraocular pressure could be normal when you examine in the presence of optic nerve damage, and you can mistake this for normal tension glaucoma. Now, I wanted to show you some examples of patients in my practice with normal tension glaucoma that have been following, and the relevance of and as to how we manage these patients. Remember, we cannot do anything about the vascular dysregulation that we talked about in normal tension glaucoma. So the treatment that we offer to these patients is still to control the intraocular pressure, and you will see that in these examples, most of these patients have undergone surgical intervention to reduce intraocular pressure below 10 millimeters of mercury, which appear to have stabilized their loss of vision field. Here is patient number 1, a 70-year-old female referred for possible normal tension glaucoma. Vision was 20/20. Intraocular pressure is 14 on 1 drop. And here is the patient's optic nerve head. And as you can see, they clearly pallor along with diffuse and shallow cupping in both eyes. Here are the corresponding vision fields. You can see dense scotoma, which is double arcade in nature, and here it's more of a dense superior arcade scotoma. In this particular patient, because of the pallor, we went ahead and did an MRI, which was found to be normal. Patient had some degree of cataract, PSA cataract, and so we went ahead and did a phacotrabeculectomy operation. And since then, the patient intraocular pressure was measured at 8 millimeters of mercury with no drops. And 9 years later, you will see that the vision fields have not progressed much, telling you that the drop in intraocular pressure from 14 millimeters of mercury to 9 millimeters of mercury has stabilized the further loss of vision field. Here is another look at the same. It is the right eye. You can see there's not much of a difference between this vision field that the patient presented with, and following the intervention, i.e. trabeculectomy, and keeping the pressure at 8 millimeters of mercury over the last 8-9 years. You can see that the vision field has not progressed. Same situation with the left eye. In fact, you can argue that this vision field is slightly better compared to what we had when the patient came initially. So, lesson learned here: if you do reduce the intraocular pressure by about 30%, these in majority of these patients, not every single one of them, majority of the patients, there is a there is stabilization of the vision field. Very important point for you to remember. Here is patient number 2, 69-year-old, sent as male, normal tension glaucoma, vision 20/20, OU, IOP 10 on 4 drops. And this particular patient was noticing this scotoma that's at the point of fixation. And because of this scotoma getting denser on previous vision fields, we opted to go ahead and do a trabeculectomy procedure again for him and this particular patient, and drop the pressure to 8 millimeters of mercury. And as you will see, this was the vision field of this particular eye in 2004, 2011. It became a little dense, but has not progressed much. And you will notice that the paracentral scotoma in the inferior paracentral scotoma also has not changed much. So some degree of stabilization has been achieved in this particular patient. And you see this repeatedly. Here is another 77-year-old female with normal tension glaucoma. When she first presented, IOP was 18 on 3 drops, and the patient had a vision field, especially in this particular eye, extending as a nasal step into the fixation. 8 years later, with intraocular pressures with around 8 millimeters of mercury following trabeculectomy operation, here is what you will see. You notice that the vision fields have not changed much. This is the left eye, and again, you can see that it has not progressed much. So the previous 3 patients demonstrate to you that if you lower the intraocular pressure by about 30%, you can stabilize their vision fields. I have a whole series of patients with non-mortician glaucoma that I operated on in my practice, and have been following them for the last 8, 10, 12 years now. And every one of them, fortunately, have stabilized. They have not progressed. It may not be true for every single patient because studies do suggest that about 10-20% of them will progress in spite of intraocular pressure, successful intraocular pressure control. Now, as I was mentioning to you, there are some patients who will present to you as non-mortician glaucoma, but they really don't have non-mortician glaucoma. They may be having some other etiology going on. As is seen in this particular patient, a 65-year-old was being followed by a different glaucoma specialist as non-mortician glaucoma, with a diagnosis of non-mortician glaucoma for over 3 years. Highest IOP was 19. The patient was on these 3 medications, and these are his vision field, his optic nerve appearance. As you can see, he's got this characteristic optic nerve with pallor and diffuse shallow cupping, more so in the right eye than in the left side. And here is the left vision field, which was completely normal. Here is the right vision field, where you have this dense scotoma hiding the midline. And they had, and this scotoma was gradually getting worse. And at this point is when the patient was referred to us for second opinion. Remember, in the differential diagnosis of non-mortician glaucoma, I said be aware of pallor, and also by definition it should be a bilateral disease process. If the pallor is out of proportion and the scotoma is much denser in one eye, it should raise the suspicion. So this particular patient had a CCT of 511, 513, visual acuity was 20/20 in both eyes, gonioscopy open angles, serial tonometry 9 to 13 on these medications, and the carotid Doppler showed less than 50% stenosis bilaterally. We did go ahead, because of the presentation, we did go ahead and get an MRI to rule out intracranial pathology, which was found to be normal. And so then we asked the patient what else, what are the medications he takes, and as he was walking out, he casually mentioned that he's a health freak and that he takes about 2,000 milligrams of niacin a day. We looked up on niacin. As you all may know, there is a documentation that niacin causes vasodilation, and it can cause a drop in the intraocular pressure, blood pressure. And this patient was in the habit of taking niacin 2,000 milligrams at 6 o'clock in the evening every single day. And he reported that soon after he takes it, within half an hour, his entire body gets warm and pink, and lasts for about four hours. And by 10 o'clock, he's back to normal. So I asked him to check his intraocular pressure while on niacin, serial intraocular pressure reading right through the day while he's on niacin, and then we told him to stop taking the niacin and to recheck his intraocular pressure. And as you can notice here, while it was on niacin, his blood pressure dropped down to 99/59, and when we took him off niacin, his intraocular pressure was between about 120/70. So this particular patient, I believe, was having periodic hypotension related to niacin usage, and so and that is compromising the function of the optic nerve head on his right eye. This was his vision field at presentation in 2011. And we stopped the niacin and we followed him since then. And as you can notice, his vision field actually has gotten significantly better. He still has a tiny fixation scotoma there, but nothing compared to what he presented with. And it's interesting that the scotoma has gotten better, and he does not notice the scotoma anymore. When he first presented to us, he clearly was able to delineate the scotoma in his vision field. So this particular patient has gotten better since his hypotensive episodes have decreased or have been abolished, in fact, by discontinuation of niacin. The reason why I want to present this case to you is to bring to your attention the difficulty in making the diagnosis sometimes. And so you always have to question these patients about any episodes that can lead to hypotension, anything that is suggestive of intracranial pathology, and medication-induced changes that can cause damage to the optic nerve head. And that can mimic normal-tension glaucoma. So when to do neuro workup in these patients? When there's marked asymmetry or unilateral optic nerve involvement, optic nerve pallor in excess of cupping, unexplained vision loss, color vision loss in the absence of vision loss, visual field loss out of proportion to optic nerve changes, and vision field loss respecting vertical midline. Any of these changes, you need to work up these patients by ordering an MRI and ruling out intracranial pathology. That brings us to the collaborative normal tension glaucoma, CNTGS, a great study that was done by Doug Anderson from Miami, wherein they enrolled patients with normal tension glaucoma, and they studied they postulated that the only treatment that can be offered to these patients was intraocular pressure reduction, and so they controlled the intraocular pressure, and the study followed these patients for more than 5 years, I believe. And here are the conclusions: 30% reduction in the IOP reduced the vision field loss from 35% to 12%. And in the observation group, 65% did not progress versus 12% who progressed despite aggressive treatment. So if you observe these patients with normal tension glaucoma, about 65% do not progress. And maybe this particular category of patients had some other disease process that affected the optic nerve, like we discussed before, and we just could not find them. But in any case, in this particular study, 65% showed no progression, even though they were being observed with no intervention, whereas in the group that had a 30% reduction in intraocular pressure, in spite of aggressive intraocular pressure control, 12% of them progressed. So there were, like I mentioned before, there's a certain small percentage of patients will continue to progress in spite of adequate intraocular pressure reduction, and at this point we don't have a treatment that we can offer to these patients. So the treatment and prognosis for patients with normal tension glaucoma, lower the intraocular pressure, and that's the only thing that we can offer to these patients at this point. Once you confirm that these patients do not have other etiologies. Medications, so what do we start these patients on? Prostaglandin analogs appear to be the first line of choice by both by myself and most authorities in this field. There is a paper that came out several years ago suggesting bromonidine to be a neuroprotector, i.e. urafangin, and they demonstrated in that particular paper by Ted Krupin that bromonidine somehow, because of its so-called neuroprotective action, improve the vision field and decrease the vision field loss compared to timolol. This particular observation was not observed by other glaucoma specialists, and has to be proven again. The reason for this is that bromonidine, when applied as topical medication, the amount of this drug that will reach the ganglion cells and the axons in the posterior vitreous cavity is questionable. And as such, I'm not so sure as to how this effect has translated into better vision field in this study. Bromonidine as a neuroprotector is based on animal model studies, just so you're aware of it. But it's when in doubt, to give the benefit of doubt, I do start these patients based on this particular study. If prostaglandin alone is not doing the trick, I do not hesitate starting these patients with bromonidine. We would like to try to avoid beta blockers as first line in these patients because of the potential vascular compromise or decreased circulation that the beta blockers may have. And you don't want to compromise the circulation in an eye that is already compromised by vascular dysregulation. Calcium channel blockers, do they have a role? In the idea being because of vascular dysregulation, there is decreased circulation going on to the axon. So why not use a drug that can cause vasodilation and increase the circulation, right? And so calcium channel blockers naturally come to your mind in this regards. But systemic calcium, we don't have a topical calcium channel blocker that you can administer that will reach in sufficient concentration the axons. So people did try systemic calcium channel blockers, and there was some, at least one paper from Mass India when there was a fellow there suggesting that systemic calcium channel blockers may have a protective role against glaucoma. But to purely start the patient on normal tissue glaucoma on calcium channel blockers, you need to get a cardiologist or primary care doctor to work these patients up, because the systemic side effects were too much, and a lot of patients do not tolerate calcium channel blockers. And so I myself have quit trying these calcium channel blockers because of the systemic side effects. It's something to keep, something for you to think about in an isolated patient where you did reduce intraocular pressure by 30%, and in spite of that, these patients they continue to lose vision. Something that you can think about. SLT or ALT is as part of your treatment is okay in these normal tissue glaucoma patients, but don't expect a dramatic drop in intraocular pressure, because the starting intraocular pressure is only 14. Even in a most effective case, you may expect a drop by about 2 or 3 points. So ultimately, a lot of these patients, if they have progressive worsening vision field, will end up having trabeculectomy with mitomycin C, because you want to lower the intraocular pressure below the episcleral venous pressure. And the only way that you can successfully do this is by performing the trabeculectomy operation with mitomycin C. So the number one go-to procedure in my practice is trabeculectomy with mitomycin C. TRAB is the way to go in these patients, okay? And I'm writing T for TRAB here. So if you have a patient with vision field loss in spite of aggressive medical management, and it's threatening the vision, the fixation, do not hesitate suggesting and performing a trabeculectomy operation with mitomycin C. So in the future, there's a role for neuroprotection. We did discuss this as part of our initial lectures, so I'm not going to go spend too much time. But obviously, most of glaucoma, the future will belong to neuroprotection if we can crack this puzzle as to how to identify a neuroprotective agent, and B, deliver this neuroprotective agent in sufficient dosage to the damaged site, i.e. the axons and the ganglion cells. Then we would be hopefully protecting a lot of these patients from going blind. So after talking to my residents, I realized that I need to include a slide at the end of my lecture for each one of these sections titled high yield, meaning those points about this particular disorder or lecture that you need to remember from your exam's point of view. So here is the high yield for normal tension glaucoma. Bilateral and progressive disorder with intraocular pressure less than 21 millimeters of mercury, visual fields which are more focal, deeper, and closer to fixation, especially early in the disease. Optic nerve changes could be either senile, sclerotic, or focal ischemic group. Normal tension glaucoma is a diagnosis of exclusion. See, the collaborative normal tension glaucoma study suggests that 30% reduction in intraocular pressure stabilizes the vision field in majority of the patients. Prostaglandin analogs is the first line of treatment in majority of these patients. Consider CNS vascular causes in atypical presentation. There you go. Here is my reference on Doug Anderson's paper on normal tension glaucoma in the Indian Journal of Ophthalmology and the collaborative normal tension glaucoma paper that came out in American Journal of Ophthalmology in 1988, classic paper that I would encourage everyone to read. Now let's move on to the next topic in secondary open-angle glaucoma, which is exfoliation in glaucoma. Alrighty, so the history of exfoliation is kind of interesting. First identified in Scandinavian population in 1917, Lindberg from Finland and Malling from Norway. They both reported similar findings of white grayish material on the lens and the pupillary margin and in the angles and in association with what they called a simple glaucoma in those days. What in 1923 to 32 published the first accurate description and thought this represents superficial layers of lens capsule. And he called this particular kind of glaucoma as glaucoma capsulaire. It was left to Georgina Duarte-Thibault in 1954 to coin the word pseudo-exfoliation to differentiate exfoliation from true exfoliation in glass blowers, which is a profession that is slowly dying, and so probably none of you youngsters out there would see this, but in the old days there used to be a lot of glass blowers, and these people used to develop exfoliation of the lens capsule. And because most of it is mechanized now, you don't see this disorder anymore. And so Thibault coined the word pseudo-exfoliation to differentiate this from true exfoliation in glass blowers. Okay, so the name pseudo-exfoliation syndrome stuck ever since then. It's a systemic disorder of the basement membrane with poorly characterized fibrillar substance produced in abnormally high concentration within the ocular tissue. So this is a basement membrane disorder that's seen in other structures of the body. But the peculiar thing about this systemic disease disorder is that the disease process affects only the eye in regards to glaucoma and lenticular changes that we'll go through in the next few slides. The cells lining the posterior surface of the lens, iris, and non-pigmented ciliary processes. Now, all these three structures are lining the posterior chamber. They found extrude PEX material or pseudo-exfoliative material on their surface, and then what carried by the aqueous into the anterior chamber, from the anterior chamber into the trabecular meshwork, and cause obstruction to the outflow pathway, leading to elevated intraocular pressure. So the actual material that's causing the disease process is from the cells lining the posterior surface of the lens, iris, and the non-pigmented ciliary processes. Remember, this is the area that lines the posterior chamber or outlines the posterior chamber. So this material comes out of these cells, then it gets washed out by the aqueous into the antechamber, and then subsequently through the trabecular meshwork, gets trapped in the juxtacanalicular area, cause long-term fibrosis and elevated intraocular pressure. So the incidence of pseudoexfoliative syndrome is much higher in Scandinavian descent population, 20 to 25% of all open-angle glaucomas. In the US, it's been reported anywhere between 0.4 to 28%. It's not restricted only to Scandinavian descent population. It's been reported all over the world, even though it is more common in the Scandinavian population. Accumulation of PEX or the pseudoexfoliative material, like I mentioned in the GXT or the juxtacanalicular area, causes focal collapse of the Schlemm's canal, leading to increase in intraocular pressure. Also remember this material, coming out from the lens epithelium in the area where the zonules are attached, could lead to zonular weakness. Okay, so that's the pathogenesis of this disorder. In terms of genetics, it's less clear. It could be autosomal dominant, autosomal recessive, or maternal inheritance patterns, all of which have been described. The gene that has been associated with this disease is called the LOXL1 gene, lysyl oxidase like 1 gene. It's found to be defective. This LOXL1 gene plays a role in cross-linking of collagen and elastin, and of course, a defect in this combination could lead to zonular weakness and also subsequent damage in the PEX, in the juxtacanalicular outflow pathway systems. So exfoliation syndrome. Now, I dropped the word pseudo when from here on, simply to reflect that your BCSC book calls this as exfoliation. The terminology has changed a little bit. Some people still refer to this as pseudoexfoliation. Some people are using the word exfoliation. In both cases, remember, they're talking about the same entity here. This is the most common form of secondary open-angle glaucoma, accounting to 20 to 25% worldwide. It's rare below the age of 50. Mostly seen over the age of 70. 40% of pseudoexfoliative syndrome develop open-angle glaucoma over 10 years, and it's oftentimes monocular at presentation. Very important point for you to remember to distinguish it from the primary open-angle glaucoma patients. And in this picture, you can clearly see the fluffy material in a dilated pupil. So you got to dilate this for your patients to examine the lens surface for you to detect this fluffy material, especially in the initial few stages. This fluffy material can also be found along the pupillary margin. You can see it on the cornea. You can see it in the trabecular meshwork area on gonioscopy. You can see in this picture the pupillary margins or the fluffy material lining the pupillary margin. And you can see pigmentation in the angle, which is patchy compared to pigmentary glaucoma. And that's because of the PEX material embedded between the pigment. So this patchy pigmentation of the trabecular meshwork and anterior to the Schwalbe's line, and that pigmentation in the Schwalbe's line is called Samples' line, named after the guy who described it, I'm sure. And this kind of a picture is typically shown to you in your OCAPs or your board exams. And also important for you to remember when you make the diagnosis. These patients can have a shallow anterior chamber, and the reason for that is, remember we talked about weak zonules. So when the zonules become weak, what happens to the lens? The lens rides forwards. When the lens rides forwards, the antechamber becomes shallow. Simple. They have peripupillary atrophy. This is pretty characteristic for this disease process. So if you look at the pupillary margin, you will notice on retroillumination, transillumination defects in this area, as opposed to pigment dispersion syndrome, where the transillumination defects are in the mid-periphery. somewhere in this area. So transillumination defects are seen both in exfoliation and pigmentary glaucoma, except the location is different. In exfoliation syndrome, it is peripupillary, whereas in pigment dispersion, it's mid-periphery. Scattered diffuse iris depigmentation with transillumination defects that we just went over. Phacodonosis or iridodonosis are much more common in this disease process, and abnormal iris muscle leakage on fluorescein angiogram. So what is this material? It resembles amyloid, but it's not exactly amyloid. And histology found this material to be in and on the lens epithelium and the capsule pupillary margin, ciliary epithelium, iris pigment epithelium, iris stroma, blood vessels, and subconjunctival tissue. So you practically find this everywhere in the anterior chamber. This fibrillar material that resembles amyloid. So all these cells, the basement membrane appears to be defective and produces this fluffy material that gets extruded from the cell surface and gets washed out with the anterior chamber. And this material can be found on top on the corneal endothelium, and some of these rarely can lead to corneal decomposition and corneal edema. So compared to primary open-angle glaucoma, I should have mentioned a P here, which I will do right now. So compared to primary open-angle glaucoma, these patients with exfoliation syndrome have higher intraocular pressure, more likely to be monocular at presentation, and will have pigmentation in the angle. And these patients are resistant to medical treatment, and overall prognosis is worse. Now, this is in comparison to primary open-angle glaucoma. Now, this again is important for you not only to remember this from the treatment point of view, but also from your board's point of view. Now, remember, lens extraction does not cure this condition. ALT can be effective, but for a short time. Trabeculectomy has good results, and expect more inflammation following surgery compared to primary open-angle glaucoma patients. So how do you manage these patients? Obviously, you want to try, when they present to you with elevated intraocular pressures, you want to try the regular glaucoma drops. You can do ALT and eventually trabeculectomy operation. Now, in regards to the cataract in association with exfoliation syndrome, remember we talked about weak zonules. This can lead to zonular dehiscence, shallow chamber, and the pupil does not dilate properly in this patient. So you will have a small pupil when you're going to do the cataract surgery. So the cataract surgery becomes difficult, and there's a higher likelihood of vitreous loss in this patient. So you have to be careful about this. These patients, some techniques and experience is needed for you to master cataract surgery in these patients with exfoliation syndrome. Here is a particular patient of mine who presented with a dense 4+ brunescent cataract with pseudoexfoliation and subluxation. I did a cataract extraction on this patient, saved the capsular bag, and put a 3-piece lens in the bag, sutured it to the iris, as you can see in this area and in this area. The patient did great. You just have to be familiar with these situations and plan for this kind of surgery in advance. And we'll show you some surgical videos later during our surgical lecture series. Sufficient for you to know that these cataracts are difficult and they're associated with big zonules, and zonular dehiscence is to be expected in these patients, and also that the pupil does not dilate properly. Some of these points are frequently asked in your boards. So here is the high yield slide for pseudoexfoliation syndrome. Possible spontaneous dislocation is common in this syndrome. Earlier cataract formation is seen. Higher incidence of vitreous loss during cataract extraction. They exhibit volatile intraocular pressures compared to primary open-angle glaucoma. They can present to you with narrow chamber angles, secondary to, again, zonular weakness. most common cause of acquired zonular insufficiency and lens subluxation leading to pupillary block mechanism. And also, one of the things that I should have added here, this is the most common kind of secondary open-angle glaucoma worldwide. Here is a reference by Dr. Rich, a great paper that I would recommend everyone to go through. Dr. Rich also published a considerable amount of literature on pigmentary glaucoma that I would encourage you to read. So this leads us to the last entity in this discussion, pigmentary glaucoma. From the historical perspective, Sugar and Barber reported the first two cases in 1949. I could not find any other history prior to this of pigment dispersion syndrome. Pigment dispersion syndrome is an autosomal dominant disorder with incomplete penetrance, typically seen in young white males. And the chromosome that's been identified or linked to this disorder is 7q35. It has an increased incidence of retinal detachment associated with it. Pigmentary glaucoma is seen in a third of patients with pigment dispersion syndrome. So not everyone with the PDS or pigment dispersion syndrome will progress to pigmentary glaucoma. About a third of them do so. The more myopic the patient is, the more likely that they will progress to pigment dispersion syndrome. As I mentioned just now, to reiterate that fact again, about a third of these patients will develop glaucoma, more likely to happen in myopic males. Affected females are older compared to males. And these patients will need a dilated fundus examination at presentation and every year thereafter, because they are associated with a higher incidence of lattice degeneration, and retinal detachment is much more likely to happen in PDS patients compared to normal population. The incidence is reported as 6.4%. Now, this lattice degeneration has been, the higher incidence of lattice degeneration is in relation to comparison to age and refractive or unmatched population. So it is mandatory that you examine these patients following dilated fundus exam. So what are the signs of this pigment dispersion syndrome? Transillumination defects of the iris. These are noted in the mid-periphery of the iris from rubbing against the zonules. As can be seen in this particular picture, you can see the mid-peripheral transillumination defects, Krukenberg spindle, vertical collection of pigment along the corneal endothelium, which is what this slide is supposed to show. Non-specific for, but this Krukenberg spindle is not specific for pigment dispersion syndrome alone. It can be seen in other disorders such as trauma, uveitis, etc. And of course, pigment in angle, which is what this slide is picture is supposed to be showing. It's dense, uniform, and 360 degrees. Unlike the patchy pigmentation that you notice in patients with pseudoexfoliation. There are several other things that you need to understand. The concept of posterior iris bowing with reverse pupillary block. Let me see if I can draw a diagram to explain this to you. Okay, if this is the cornea, here, see, here is the anterior chamber. Here is your lens. This is the normal iris, which is lying on the surface of the lens, whereas here you can see that the iris is flat as opposed to in pigment dispersion patients where the iris is bent backwards in a concave fashion. So because of this posterior convexity, what happens is that this portion of the iris is rubbing against the zonules, lens iris, the lens zonular complex here, releasing pigment from this area. Because of this constant rubbing motion and lack of release of pigment, this area will exhibit the transillumination defects in the mid-periphery. So the concept of reverse pupillary block is this. These patients probably have some kind of a genetic disorder or weakness in this iris for it to be floppy posteriorly. And the intraocular pressure in the anterior chamber being higher than in the posterior chamber will push the iris to bend backwards, causing this rubbing motion against the zonules every time the pupil constricts and dilates. They have ultrasound proof, I think, that every time the patient blinks, the blinking motion would cause the IOP the aqueous to be pushed down and the posterior chamber pressure to increase, causing the aqueous to escape out through this reverse pupillary block mechanism into the anterior chamber. In any case, these patients have this posterior iris bowing, rubbing against the zonules. That's where the pigment is getting released, and this released pigment is carried by the aqueous and gets deposited in various structures of the anterior chamber, ultimately finding its way into the trabecular meshwork, where it does get trapped and subsequently cause intraocular pressure to be elevated. So there are a couple of names that you need to remember from the exam point of view: the Z-Meyer line, or the which is pigment on the posterior lens capsule near the zonular insertion. Here is an example of that we're trying to show you. Egger's line, which is pigment on the anterior hyaloid capsular ligament. So this pigment can get deposited anywhere in this anterior segment. And the guy who first described it got his name attached to it. Super, right? So to remember, pigmentary glaucoma, a third of the pigment dispersion syndrome patients will go on to develop pigmentary glaucoma. The intraocular pressure in these patients fluctuates widely. The IOP spikes during exercise and dilation. And so it's not uncommon for these patients, especially after jogging or following dilation, to develop, to release a burst of pigment into the anterior chamber, which will block the trabecular meshwork, compromise the trabecular outflow pathway even more, causing the pressure to shoot up to 40s and 50s. And because of the sudden spike in the intraocular pressure, these patients can develop mild corneal edema and halos and vision blurring. And it's not uncommon for these patients to walk into the emergency room in this kind of situation and misdiagnosed as uveitis because of the number of pigment cells that they exhibit in the anterior chamber with elevated intraocular pressure at that time. I've seen that in my own practice, referred in as uveitis. So the differential diagnosis for pigmentary glaucoma includes pseudoexfoliative syndrome. Now remember, pseudoexfoliation is seen in older age compared to pigment dispersion syndrome, which is seen in younger age population. Pupillary margin transillumination defects are present in pseudoexfoliation. We went over this before, as opposed to mid-peripheral transillumination defects in pigment dispersion syndrome. Angle pigment is patchy and less dense in pseudoexfoliation syndrome. Presence of whitish exfoliative material on the lens pupillary margin and angle clearly will point towards the pseudoexfoliation, whereas in pigmentary glaucoma, you will have pigment being present in these areas. Trauma can sometimes mimic pigmentary glaucoma. Look for angle recession along with the pigment. Tumors, ciliary body melanoma invading the angle can present with angle pigmentation. Uveitis, Angle pigment is patchy. Look for KPs and PAS. And intraocular lens chafing. The patient had a complicated cataract, the lens stuck in the angle in the sulcus, single piece versus three-piece IOLs, or presence of phakic intraocular lenses in high myopes. All of these situations can cause rubbing motion of the mid-peripheral iris against the underlying plastic lens and release the pigment. And this is a secondary cause for pigment dispersion, pigmentary glaucoma. We do see this. This is not uncommon. Right now I have like two patients referred in the recent past with this condition, and the way to solve this issue obviously is to reposition that lens in the proper location to prevent pigmentary chafing. The iris chafing. So the clinical course of these patients, pigment dispersion syndrome may burn out with age. And how does this happen? It's secondary to lens thickening as we grow older. It causes relative pupillated block, pushing the peripheral iris forwards and away from the zonules. And so consequently, you will have less pigment being released. So remember I told you only a third of these patients will develop pigmentary glaucoma. The rest of them will never develop glaucoma. So we need to follow these patients, but also important to notice that a lot of these patients do not develop glaucoma as they grow older. And the reason for that is the physiologic lens thickening that's happening that will push the peripheral iris away from the zonules. Some patients with pigmentary glaucoma may present with very high intraocular pressures and are difficult to manage. I have a patient currently who presented with intraocular pressures of 50 on Diamox and 3 drops. They can have intermittent, transient, and rapid intraocular pressure spikes from dilation or exercise, something that you need to be aware of and make the patients aware of this situation so they can modify their exercise regimes or can initiate anti-glaucoma medications prior to exercise so as to prevent the spikes. In comparison to primary open-angle glaucoma, they're less responsive, just like pseudoexfoliated glaucoma. Initial medications treatment would be in terms of glaucoma medications, drops, similar to primary open-angle glaucoma. So you can start the patients on prostaglandin analogs or a beta blocker. Myotics have the advantage of increasing the trabecular meshwork outflow while reducing the posterior iris bowing. But be aware of intolerance and risk of retinal detachment. And so something that we don't use that commonly in my practice, but I do know that there is a significant number of patients on the pilocarpine in these patients, and the concept there is to, instead of having the iris bowed like this because of the use of pilocarpine, the stretching on the iris, and you will straighten the iris, and consequently the posterior rubbing motion against the zonules is decreased. But you have to weigh that against the intolerance and risk of retinal detachment, because a lot of these patients are young myopes, and the intolerance of pilocarpine is pretty significant in this patient population. Now, the other thing that I have not mentioned here, but I should have mentioned, is to perform iridotomy. Iridotomy, the concept there is if you make a hole in the iris, which is bowing posteriorly, it will equalize the pressure in the anterior chamber versus the posterior chamber, as the fluid will bypass the reverse pupillary block mechanism and travel into the anterior chamber through the iridotomy. But this procedure has not found to be of any practical use, meaning that yes, the iris may become a little straighter and demonstrated conclusively on ultrasound imaging systems, but it has not reversed the clinical course of the disease process, and as such is not being advocated and not used at this present time. I do not do the PIs anymore on these patients. SLT or ALT, they have good response, but short-lived. Be aware of, and the reason why it's short-lived is because of the continued release of the pigment that feeds into the trabecular meshwork. Be aware of the post-laser IOP spikes in these patients, so use less energy, treat less area, and use post-laser adrenergic agonists to decrease the risk of spike. So when you see a lot of pigment in the angle, note that the energy that is absorbed by the pigment is much higher, and that's the reason why you want to use the least amount of energy to get away with. And typically, if you're using SLT in a patient with 3+ pigmentation, I start off with maybe 0.2, as opposed to 0.8 in a normal patient with no pigmentation. If you're doing ALT, you may want to start off with 100 rather than 800. But you got to titrate the amount of energy that you're placing into the angle. You don't want to see even a blanch in these patients. And so be aware, and also treat less area. Normally deliver about 70 to 80 spots to 360 degrees in primary open-angle glaucoma patients, whereas in dense pigment patients with pigmentary glaucoma with dense pigmentation in the angle, I might do just 30 or 40 spots scattered throughout. And there are some who advocate doing only 180 degrees with low energy. Either way, the concept here is less energy, less number of spots to be delivered, and watch out for this IOP spike, which is real. This particular patient that I'm going to present next, you will see that this patient had ALT done and the pressure shot up to like 70 millimeters of mercury. Trabeculectomy has good results, but be aware of hypotony maculopathy in these patients because these are all young myopes. I switched myself to deep sclerectomies and canaloplasty procedures in these patients, and I think may not be a bad idea in these particular patients now that we have the stents available. Literature suggesting continued success is not there yet, but there are some reports out there suggesting good response to iStent implantation in this particular patient. Here is an example of a patient from my own practice that I recently saw, a 46-year-old who was referred in for a pigmentary glaucoma management. Vision was 20/20. Intraocular pressures was 34 millimeters of mercury in the right eye and 48 in the left eye, and 3 drops in Diamox. Gonioscopy revealed dense pigmentation in the angle, optic nerve 0.4 and 0.7 cupping. Vision fields were still normal. Here is the Krukenberg spindle in this particular patient. You will notice dense pigmentation in the angle. In the right eye, pressures were 34 on max medications, and we plan to perform surgery in this particular eye in the near future. Here is the left eye that presented with pressures of 48 on max medications. I chose to perform canaloplasty in this particular patient, and don't have a picture of the gonio before canaloplasty, but I swear the patient had 3 to 4+ dense pigmentation, but after canaloplasty, the amount of pigmentation is decreased. This is 1 month post-op, and you can see the blue line of the proline suture in the canal. Intraocular pressures controlled at 15 millimeters of mercury within 1 month. The vision was back to 20/20 with her prescription that she is wearing, and patient is happy. We are planning on doing a similar surgery in the right eye. I did do canal surgeries in pigment dispersion syndrome patients, pigmentary glaucoma patients in the past, and have found good success in this particular patient population. On the other hand, I was forced to do a trabeculectomy operation, and a young 16-year-old who presented with pressures of 68 millimeters of mercury in his left eye. He was a national bowling champion, nationally ranked bowling champion, and he noticed one day that he could not see out of his left eye, and his pressures were found to be close to 72 millimeters of mercury, and that's when I saw him. I don't have his pictures right now on me, but he did not respond to medications. This was about 7 years ago when we were beginning to do canal surgeries, and he's a high myope at minus 13, I believe. As is this particular patient that I'm presenting. The insurance company denied any other procedure other than trabeculectomy. I did warn them about the risk of hypotony, which is so I did do the trabeculectomy operation with tight sutures, etc. In spite of which, patient ended up developing hypotony maculopathy, which I corrected, of course, but ended up having 2 procedures, and he's doing great. I mean, in the long term, I recently saw him 6 years after the trabeculectomy operation in both eyes. His vision is stable. His pressures are stable between 10 and 14 millimeters of mercury all these years. So they do well. I mean, these patients respond well. It is up to us to choose the right surgical intervention that is needed for this particular patient group, and do the necessary treatment as is needed. So from the board's point of view, here is my high yield slide. White pigment dispersion syndrome and pigmented glaucoma more likely to be seen in white myopic males aged between 20 and 50. They will have Rubinberg spindle, but the spindle is not the mnemonic to pigmentary glaucoma. It's seen in other disorders such as trauma and uveitis. Zettmeyer's line, again, a deposit of the pigment along the zonular attachment, in the area of zonular attachment of the lens equatorial region. Spoke-like iris transillumination defects in the mid-iris periphery, IOP spike after exercise and pupil dilation, reverse pupillary block mechanism, something that you need to understand, and that iridotomy has been found to be of no clinical use in manipulating the course of the clinical course of this disease process. Remember, the risk of hypotony maculopathy is increased if you do perform trabeculectomy operation in these patients, especially if you want to use mitomycin C. Remember, if you want to do ALT or SLT, it requires less energy because of the risk of pressure spikes. So that concludes our lecture on secondary open-angle glaucoma. Important topic for you to understand and be aware of when you see these patients in the clinic. As usual, I thank you for your patience and for taking the time to attend our lecture series. So look out for more lectures on MediTread YouTube website, and also look out for our upcoming CME board review courses. If you have any questions or comments, please send me an email at ayala@meditread.com or ayala@tulane.edu. Thank you. You have a good day.